Hello, everybody, and welcome back to part 3 in exam 3 of our PPI exam review. Last time we talked a little bit about neurotransmission, and today we're going to be talking about the sympathetic nervous system. Um, and this is a division of the autonomic nervous system, which we talked a little bit about last time. This is essentially, you can think of it as kind of our fight or flight system. So a lot of the responses that you're going to see in our body are things that happen when we are like excited or scared. But yeah, with that, let's just get into it. So let's talk a bit about receptors because that's going to be a huge part of your exam. A diagram like this, you're kind of just going to need to know at least the general thoughts of. So I definitely recommend like maybe screenshotting this or having like a blank diagram of this. Maybe that's something I can even look into doing. If I get a little bit of time, check the description to see if maybe I have a blank diagram of that. I might not have it this year just because I'm a little bit backlogged with videos right now and trying to get those done. But if I do get around to that, you should be able to see that in the description. But essentially, let's go through this like one by one. So we have our alpha 1 receptors, and these will dilate your pupils. Why does it do that? So essentially, when you're in a state of like fight or flight, you will need to take in more light. You will need to be able to see what's around you. So if you think of this from a fight or flight response, a lot of norepinephrine and epinephrine, aka adrenaline, will be released and stimulate these receptors, right? Take in more light, see more, see the danger that's around you. Um, this is a little counterintuitive. Our alpha 2 receptors, there are a few places in our body. They're usually more centrally. And when I say centrally, I mean in like the brain and spine, the spinal cord. Um, these are almost like the opposite of what most alpha receptors will do and sympathetic receptors in general. These are actually, they're like a negative feedback mechanism, right? So these are receptors that will like release norepinephrine when stimulated at low levels, which is good. You know, it upregulates the rest of the system. So in that regard, it's not negative feedback. But what happens if there's too much norepinephrine? If it rises too much, these will actually be downregulated. So let's say we have too much norepinephrine, it rises too quickly. Alpha 2 will actually block norepinephrine. So we actually have some classes of drugs that'll deal with that. We'll talk about that a little bit coming up here. But our alpha 2 agonists, meaning they attack alpha 2, but they turn on alpha 2 receptors would probably be the best word. If they turn them on too much, it's going to down-regulate norepinephrine. And something we'll see here in a second is since norepinephrine works on blood vessels to constrict them to make our blood pressure rise, less norepinephrine will cause less of that constriction. It'll make our blood pressure fall. So our alpha 2 agonists are usually used for blood pressure, and then they're also used for ADHD. I don't know the exact mechanism behind that one, but that's another use. So another alpha 1, similar to our eye, alpha 1 will inhibit saliva production. Why does this happen? Or just secretions in general, not just saliva. There's also some alpha 1s in our eyes that'll stop like tear fluid from building up. Essentially, like membranes being moist isn't a vital function in a fight or flight situation. So our body will turn it off, right? Because we kind of need our energy going elsewhere. We don't need to like digest during a fight or flight situation. We don't need to produce a ton of saliva because we're not trying, because if you remember from probably Anatomy 1, your saliva has enzymes in it that will help digest food. If we're running away from a bear, we don't need to digest food. So we turn that off, and we'll see that in a few other systems in our body. Beta receptors. So something important to note is beta 1 receptors, the only location for beta 1 are in the heart. And this will essentially dictate how fast your heart beats, or how strong it beats. So if you have something that agonizes beta 1, turns it on, your heart rate will go up, right? Because if we are running away from a bear or like a dangerous situation, we need our heart to pump blood to get oxygen to the body. So that'll be upregulated. Beta 2 also has some effect on heart rate, but generally when you think of beta 2, we'll think of it in two kind of locations primarily. We'll think of it in the bronchi, um, in case you don't remember from your anatomy classes, the bronchi are in the lungs. They are essentially like they are where gas exchange happens in your lungs. And if they're dilated, that means we can have more gas exchange in the lung. It creates a greater surface area, and greater surface area means more absorption of oxygen from our bloodstream in the lungs. Um, and more oxygen is obviously good because it goes back to our thing with heart rate. We need to deliver more oxygen, which means we also need to absorb more oxygen in our lungs. So that's why those bronchi will dilate, and that's beta 2. You'll see a lot of beta 2 agonist drugs, albuterol, and really anything that ends in ol. That's an inhaler will usually be a beta 2 or agonist. So that's a use for those. And we'll talk more about that coming up here, but that's like where you've probably seen it before. Um, like I mentioned before, alpha 1 will constrict blood vessels. Um, the reason for this is it won't constrict all blood vessels, which we'll get to in just a second here. This will constrict mostly like blood vessels that will be in like your intestines or like glands. So why is that? It goes back to our whole thing, right? The whole point of our intestines and our glands are to like digest and do processes we don't need when we're running for our life. So these blood vessels will constrict. You get less oxygen and less nutrients to those areas because that's not where our body needs our oxygen and nutrients to be. There's a type of blood vessel though that will dilate. This is the other use for beta 2. These two are the big areas where beta 2 is. Technically, they also work in the bladder, but honestly, you probably won't get asked that. I'd usually think of beta 3 when I think of the bladder. So for now, let's just pretend that there's only two areas where beta 2 are. And it's dilating those bronchi, your, your airways, you can get more oxygen in your blood. And then how do we get more, beyond just having oxygen, how do we get more nutrients and oxygen to our tissues? Like what can increase that rate beyond just absorbing air? And that would be actually by dilating our skeletal muscle blood vessels. And when I say skeletal muscle, I mean like our voluntary muscles, right? So if you were to like flex something, that would be a skeletal muscle. These are muscles that we control. So you can think of those like muscles in your leg for running. We control those. And so that's something we need to control for fight or flight. So by dilating those vessels, we increase surface area and we're able to get more oxygen and nutrients to those so they can perform better. If we can get more sugar there, they can output more energy and more movement, more oxygen, obviously same thing. So that's why those beta 2s will actually dilate skeletal muscle blood vessels, but constrict digested blood vessels with alpha 1. Um, Alpha 1, very similar to up here with inhibiting saliva. Alpha 1 will slow down activity in the digestive tract. It will inhibit secretion from organs like the pancreas, which you might remember from MMP, secretes like insulin and glucagon. It's not too important to remember that, but just remember those are digestive. We don't need to digest when we're running away. So that's why that gets downregulated. And same with the gallbladder. So, like I mentioned, beta 3 in the bladder. This is just like a really specific muscle in the bladder. It's not incredibly important that you know the mechanism of it, but it'll essentially relax this muscle, right? In order to excrete urine, our bladder needs to constrict itself to push the urine out of itself. We don't need to urinate while we're running away from something. So that it'll essentially just relax that muscle so we don't have to go to the bathroom. And you might notice that like if you're on a run, you might usually not have to go to the bathroom. And this is part of the reason why. Um, and then the final one, and this is a little confusing because there's both some sympathetic and parasympathetic control of this. It induces like sexual orgasm in men and women, but also parasympathetically, it has an effect as well. So to be honest, you don't really need to like know this one. I've never seen them ask a question about this, but it kind of a fun fact, I guess, in case you were interested. Um, so that's pretty much where all our sympathetic receptors are. So these are super important just to understand those. I don't love memorizing things, especially for a class like PPI. If you remember and take away anything from this class, memorize these sympathetic receptors and memorize the parasympathetic receptors I'll be doing in the next video. Um, because these will come back. These are like, these affect, I would say, 60% of the drugs you learn in Therapeutics 1. Because when you learn conditions like asthma, when you learn conditions like hypertension, aka high blood pressure, when you learn your cardiovascular unit, all of these mechanisms come back. So really do try and memorize these if you can. These are foundational in your time here in the school. Whereas most things in PPI, to be honest, do not come back. But that's a whole different thing. So what do these adrenergic agonists look like? These are what are called catecholamines. So what is a catechol? A catechol is essentially like a benzene ring with two OH groups on it. That's it. So when you look at something like epinephrine, we have a catechol right there. So right, catecholamine. Same with norepinephrine. But these are catecholamines. So I'll write that out. Catecholamine. There's another part to that word. There's an amine. And if you remember from OChem or maybe just Gen Chem, an amine is simply just carbons bound to nitrogen. So we have a nitrogen here. We have a nitrogen here. You can see these look pretty similar. That definitely gives them different, those subtle differences or allows them to bind better to alpha sites or beta sites. For example, up here, you can see that epinephrine has the highest selectivity for alpha receptors, along with norepinephrine. This drug right here, isoproterenol, this is what we call a mixed beta agonist. So norepinephrine and epinephrine will pretty much hit all the receptors on this list. Isoproterenol will only hit beta 1, 2, and 3 receptors. It will not really hit alpha receptors. It will a little bit, but not quite to the same level. And you can see that's just probably because of this group right here. It's bulky, and alpha receptors don't like this bulky group on the end. I don't know the exact mechanism, but that could be like a reason, just that steric hindrance. But that's more of a guess. But due to this, maybe beta receptors are shaped more conducively to this, because isoproterenol is really, really good at binding beta receptors. It is better than epinephrine, which is generally like our main fight or flight hormone, and it's better than norepinephrine. Even though norepinephrine is the like hormone, or not hormone, I'm sorry, neurotransmitter, we have hitting. I guess it's a hormone and a neurotransmitter, but that's besides the point. Whenever we give it like clinically as a drug, we're almost always using it as something to target an alpha receptor, and usually to induce vasoconstriction. So the area where we do that would be over here in like our GI tract or our non-muscular kind of blood cell regions. Norepinephrine can hit all of them, but it's just epinephrine's kind of the best mixed one we have, and isoproterenol is best for beta agonism. That's not super important for the purposes of this class, but that will come back a bit in your cardiovascular unit in therapeutics. So I just wanted to put that in your mind, kind of plant that seed. Another class of drugs are phenylethylamines. So that'll be like phenylephrine. Phenylephrine is a very strong alpha-1 agonist. You might have learned about this in OTC. I think you do in allergic rhinitis, as well as ephedrine. This used to be on the market, but this was more of like a mixed agonist. This was alpha and beta, and because of that, I think it gave like a baseball player a heart attack, and they took it off the market. Because remember, if you're like artificially upregulating the system, you're constricting your blood vessels, you're increasing your heart rate. This is like a recipe for high blood pressure and a heart attack. So, and it can also be good, right? If we have really low blood pressure, then that can be something we target. But we generally don't want drugs like, phenylephrine or ephedrine to treat hypertension. We usually want it to treat hypotension or low blood pressure. And antagonists are usually what we'd use to treat high blood pressure, which we'll talk a bit about in the upcoming slides. So one more thing is that catecholamines, there are two enzymes that degrade these. These aren't incredibly important clinically, but you probably will get a question on them. There's, I'll just write their abbreviation. There's monoamine oxidase, this MAO, and then there's COMT. I believe this is something methyltransferase. It's not super important, but if you see these abbreviations, which is pretty much how they'll always be asked, these will kind of break down our catecholamines naturally in the body. These are instead of something like CYP enzymes. I mean, I think CYP enzymes can still work on these, but these are their two primary enzymes that will degrade them. So I definitely just commit those to memories, or at least like be able to recognize like, oh, there's one of these on the exam. That's probably going to change the how these catecholamines are regulated. Um, so those will degrade catecholamines. They will not degrade phenylethylamines. So an example of this is like amphetamines are like protected by these like outer groups, these ethyl groups, in order to not be degraded by these, which is why something like methamphetamine is like a much stronger, much more potent drug in the sense that it's not being broken down as easily as something like epinephrine, which when you think of like a fight or flight response, right? Like obviously in the moment it's very strong, but your body clears it out pretty quick because we don't want to be in that fight or flight state too long after like the disaster is gone. Our body will get back to its like normal homeostasis. Yeah, I think that's pretty much everything for agonism. So now, this doesn't have to do as much with like direct sympathetic. This is kind of like more indirect sympathetic responses that can be upregulated. Um, so before we were talking about like agonists, right? Or substances that would bind directly to like beta receptors or alpha receptors. So, you know, your norepinephrine, your epinephrine, your isoproterenol, drugs like this. So there's other classes of drugs though that will kind of they will upregulate this by like they can increase norepinephrine concentrations. They aren't norepinephrine themselves, but since they make more norepinephrine, we kind of think of them sorta as sympathetic agonists. It's like a weird middle ground. But an example of this is amphetamines, which I mentioned on previous slides. They will promote release of norepinephrine from these intercellular things in the synapse called vesicles. And since these will bring more norepinephrine into the synapse, we essentially will have more of these responses, right? We'll have increased blood pressure when we constrict blood vessels. We'll have dilated bronchi when we hit those beta 2 receptors. Our heart rate will go up when we hit those beta 1 receptors, um, which, you know, are all common side effects of an amphetamine. And it's not the amphetamine that's doing that, it's just the norepinephrine that it outputs. Cocaine also, it doesn't directly promote the release of norepinephrine. What it does instead is when norepinephrine is released naturally, because there'll always be some being released, it'll block the transporters that will reuptake it. So if this mechanism gets blocked, we'll have a lot of norepinephrine left in those synapses, and it'll like artificially raise those levels. You might have heard of SNRIs. These are a class of antidepressant drug. I won't really talk about them here, but that stands for selective norepinephrine transport inhibitor. It's same thing, right? It's just cocaine obviously has a lot more side effects because it's cocaine. Um, yeah, but same kind of idea, right? These drugs don't directly, they aren't hitting the receptors themselves, but they're increasing the things that do hit the receptors themselves. So kind of interesting. So just a couple of different examples there. Um, Another way this can work is, I don't know if I put a picture of this on here. Oh, yes, I did. Just kidding. Um, we also have substances that will, for example, inhibit COMT. If you remember on the previous slide, MAO and COMT break down our catecholamines, break down our NE, our norepinephrine, break down our epi, our epinephrine. And so if this enzyme gets blocked for whatever reason, we will again have more artificially, like we'll have artificially increased norepinephrine just for the fact that there's not more of it, it's just less of it is being broken down. And I don't think I have an example of a drug that does that on here. Yeah, I don't think I included an example, but just be aware that that's another way we can like artificially increase norepinephrine in these synapses. Um, Next, I want to talk about what are called compensatory mechanisms. So our body, heart rate and blood pressure are kind of mapped out in the same way, like it's related because our body doesn't want too much heart rate ideally, and we don't want too much blood pressure, ideally. So how do we kind of regulate these? So there's an equation, and it's blood pressure equals heart rate times resistance, right? What does this mean? Now, this isn't, we're not actually going to work with numbers here. You'll do this more in hypertension and your cardiovascular unit, but just being aware of this equation. So heart rate is directly proportional to blood pressure, right? If our heart beats faster, you're moving more fluid through the body, you're increasing your total pressure. Makes sense, right? Resistance is a little counterintuitive in the sense that, and well, not even really, right? If you're like constricting your vessel, like let's say this is a normal vessel, then let's say we constrict it. Vessels have more resistance when they are constricted. The smaller the vessel is, the higher the resistance. That's kind of the part that's counterintuitive. Um, but if that goes up, right? If you have the same amount of fluid in a lower space, that would increase blood pressure because you're literally increasing the pressure that's put on a fluid by the walls of the container. So these two factors will affect blood pressure. Our body likes to keep our blood pressure, at a good range. Ideally, you'll learn this in therapeutics, but the goal blood pressure that's recommended by the guidelines is 130 systolic over 80 diastolic. You might have heard 120 over 80. You might have heard some other things. It doesn't really matter. Ideally, when our body is healthy, it likes to keep these in this range. Um, so let's say we have, for one reason or another, our heart rate will suddenly spike. Let's say we gave someone like a beta 1 agonist, a specific beta 1 agonist. So remember, a beta 1 agonist wouldn't hit alpha receptors. So we wouldn't have a change in resistance. We would solely have a change in heart rate. It would make it go up. If heart rate goes up, blood pressure goes up. That's bad. Our body knows that's bad. And that would increase our chances of a heart attack or stroke. So how would we compensate for that? How we'd compensate is we would decrease our resistance, right? Because if heart rate goes up and blood pressure went up in turn, the only other part of our equation that we need to adjust is we need to make resistance go down. And how would we do that in the body? We would dilate our vessels. Because remember, if a smaller vessel increases resistance, that means a bigger vessel will decrease resistance. So we'll dilate those through one mechanism or another. That might be a parasympathetic response. That might be a sympathetic response. And very generally, actually, that will be a sympathetic response, but we'll kind of get to that more in the parasympathetic unit. There's like a very specific reason for that. So this wasn't the best example to demonstrate what I just said. But yeah, let's just say for, it's a sympathetic response, right? So like maybe we activate a beta 2 receptor. We can make our resistance go down, and then we can normalize that blood pressure. So let's take a look at this with graphs, because you will see some graphs with this on the exam. At least one, I'm sure, unless the content changes. We have a drug like norepinephrine, right? Now, norepinephrine, it increases our peripheral resistance. Like, that's the primary thing it does, right? We said it's really good at alpha-1 agonism. So if our resistance goes up, right, because if it's constricting those blood vessels, resistance will go up. What's going to happen to our heart rate in order to compensate for this, to keep our blood pressure normal? Our pulse rate is going to go down. As you can see here, well, you can see it like when these are lined up graph-wise. I mean, there's a little bit of a lag, but as that increases, our pulse rate will decrease. And you can see here, I mean, this is still an alpha agonist, right? So this is also still hitting like beta 1 receptors and other stuff, but solely looking at the alpha 1 perspective, we have our pulse rate falling and our blood pressure only goes up a little bit. Like compared to this resistance, this giant difference in these two, like this small spike is pretty good. We go from like, I don't know, what is that, 110 all the way to 120. That's pretty reasonable because our body can handle that, right? If we were getting to like a blood pressure of 180, that'd be like, oh no, that's a problem. Next up, I want to skip over epinephrine because epinephrine's a little bit stranger. I'm going to talk about isoproterenol, which if you remember is a mixed beta agonist. So what do we think of when we think of a mixed beta agonist? We think of two things actually. We think of beta 1 receptors. This will increase our heart rate. We also think of beta 2 receptors. This will increase our skeletal muscle dilation. So dilation will increase in some parts of the body. And based on this, we can see really both of those things. In this drug, there's not a compensatory mechanism because it's interesting, right? With norepinephrine, we needed the body to compensate for whatever response. For this, we don't because it's almost like a built-in compensatory mechanism. Because if dilation goes up, that, if you remember, resistance will go down. So we have resistance going down, but it doesn't matter because with that beta 1 activity, heart rate is always going up, or is already going up. So literally what happens is you can see this blood pressure is super stable because just due to the way this drug works, since it hits both of these receptors, there is no compensatory mechanism because it's just built in. Now, if this was a selective, let's say beta 2 agonist, we would only have resistance down. So what would happen in response, even if this didn't naturally happen from a beta 1 receptor? Well, heart rate would go up. And this is something you see a lot with something like calcium channel blockers. Those aren't sympathetic drugs. Those, well, they work on calcium channels. But there's different types of calcium channel blockers. You'll learn this in therapeutics. And one of them, despite being a drug for your heart and for your blood pressure, will actually increase your heart rate because it's dilating all these peripheral vessels. So kind of interesting. Now let's talk about epinephrine because it's the most common. While norepinephrine is primarily alpha activity and isoproterenol is like exclusively beta activity pretty much, epinephrine is probably the most mixed of the agonists. It has a pretty fair amount in both, if you remember from the previous slide where like I kind of ranked them. So here, epinephrine is a little weird. So we'll just look at pulse rate to start. If you remember when we looked at norepinephrine, we looked at resistance first. It kind of doesn't really matter. I mean, in the sense that like whichever receptor gets targeted first, like yeah, I suppose in that sense it matters to determine which one's the compensatory mechanism. But for purposes of like an example like this, it doesn't totally matter. So we'll start with pulse rate, right? Pulse rate or heart rate goes up. We'll want our resistance to go down to compensate. And you can see that's what happens here. Now, if you've been paying close attention, you might have noticed something. And I alluded to this on the previous slide. Beta 2 receptors, right, in your skeletal muscle, they will dilate, meaning resistance will go down. But since epinephrine is kind of a mixed agonist, alpha 1 receptors, if you remember in like your intestinal tract and other parts of your body that aren't muscles, so we'll just write like intestine, these will constrict, making resistance go up. Pretty weird, right? So it's almost like these two actually will cancel each other out. So then you might be wondering, I mean, you can see here, right? Resistance does go down a little bit. So I guess in this case, epinephrine probably has slightly more beta activity than alpha activity, but this is such a minor dip compared to like, you know, our isoproterenol and our norepinephrine. Let's just pretend this dip doesn't exist for a second. So since this dip doesn't exist, or at least we're saying it doesn't exist, why does heart rate go up? And that again is just because epinephrine is like a beta 1 agonist as well. It's increasing that heart rate just naturally. So that's how that works. So we can assume these are pretty much neutral, these two. And that's another thing. What gets really interesting is I forget if I have this on a further slide, but I do definitely want to mention it in case I didn't put it on a further slide. And if so, I'll go a little more in depth on it in a bit. What would happen if we had a drug? We're going to learn about antagonists in a second here, but I'll jump slightly ahead. What if we had a drug that would block alpha 1 receptors, right? Several drugs that'll do this, but it doesn't really matter which one we pick. But an alpha 1 receptor agonist, what that would do is that would prevent the constriction of this alpha 1, meaning our resistance would not go up if we block that. However, we would still have our beta activity, right? Because an alpha 1 receptor drug an alpha 1 antagonist would not block a beta receptor. So you can actually make epinephrine an antihypertensive agent if you were to give it with an alpha 1 antagonist, because we'd be getting rid of our constriction, we'd be getting rid of that resistance component, but we would not be getting rid of the dilating component, which would lower resistance. Which would thus, if resistance is lowered, blood pressure is also lowered at the same time. Kind of interesting. And again, I might have, I think I did put another example in that later in the slides. I made this slide deck a while ago, so if I didn't, I might add a slide at the end just going a bit over that. But that's almost like, you can almost block compensatory mechanisms in that way. So it's pretty interesting. And then finally, to finish this slide off, these are just some more of like a review of some of the clinical applications of agonism on receptors. So alpha 1 agonist, right? Constricting those blood vessels, especially in like the organs, vasoconstriction, main effect. Hypotension, right? Low blood pressure. Hemorrhage. The reason why this works is essentially if you're bleeding out, right? We don't want to lose blood. So if a lot of blood is gushing out of like an area, if we constrict those vessels, that just means less blood is getting to that area. We're losing less blood. And then decongestant as well. Similar thing, instead of like blood leaking out, on the other hand, it's more like mucus and fluid that comes from the bloodstream is diffusing across our vessels. So while we're not losing blood, we're losing fluid from blood in that area. So that's why we'd use something like, I think oxymetazoline is one of your alpha agonists you learn in OTC. For that, oh, well, phenylephrine as well. What am I saying? That's right there. Alpha 2, I said, is weird. It has like feedback with norepinephrine and how much is released. Hypertension is one, because remember, if it releases too much norepinephrine, it creates like an opposite response, a negative feedback. This is also used in glaucoma. We talked a little bit about that, I think, in our eye video. In fact, I know we did, because yeah, we had like bromoridine and like, I think we had another one on there as well. There's also subtypes of like alpha 1 and alpha 2. You can see this is an alpha 2A agonist for oxymetazoline, which this is actually a mixed alpha agonist. I don't know why this is listed here as only that, but this is used for like nasal congestion and like eye secretions. Same kind of thing we've been talking about. Also right here, beta 1 agonist, right? Dobutamine is really our only one we'd ever use as a beta 1 agonist. And that's pretty rarely used because we could always use something like epinephrine if we wanted to increase heart rate, or like another antiarrhythmia drug. These can be used for heart failure. They're not really used, but good to know that it exists. Albuterol, though, and beta 2 agonists are super well used. Will dilate those bronchi. Here it says relax. I'm going to write dilate over that because that's really what we use them for clinically. And these are used for asthma and then sometimes COPD. Depends on the classification of COPD, but which is chronic obstructive pulmonary disease. It's like really advanced asthma is the easiest way to think about it. Irreversible asthma. Mirabegron is used for incontinence, right? If we're squeezing that bladder muscle left, this is the very niche drug we talked about on the previous slide. You're not going to urinate as much. Some mixed agonism. There's a lot of stuff like Sudafed, for example. It says ephedrine on here, but that's off the market, so I'm going to write pseudoephedrine. That's Sudafed. You've probably seen that at your local store. You need to get carded for it because you can only buy so much a month. So I think you can turn it into things like methamphetamine. Pseudoephedrine is a catecholamine, just like I guess amphetamine is technically like a phenylethyl amine, but there's like some simple chemistry you can do to change that around. Don't Google that, but take my word for it. And then finally, here's amphetamine, right? Phenylethyl and cocaine. ADHD, cocaine's actually used in hospitals for like vasoconstriction and for anesthesia, so there is some use, but obviously very, not always used for pretty clear reasons. Okay, so now let's talk about alpha receptor antagonists. So up until now, we've been discussing agonists, right? Things that will turn on these receptors. Agonists aren't per se something that spelling that like agonist again. They're not something per se that will turn off a receptor. Or no, actually, yeah, that is a better way. Because if you remember from really early on, an inverse agonist will do the exact opposite thing to like what an agonist would do. So like let's say an agonist will raise blood pressure, an inverse agonist will lower it. An antagonist will just have there be no change in blood pressure. It's like turning off a light switch completely. And even if you give some agonist, like if there's antagonists in the system, it might be hard to overcome. So right now we're talking about antagonists. We won't really talk about inverse agonist for these units, but there's something to know about. So antagonism. So we have different antagonism for our alpha receptors. We have non-selective. If you remember, there's two types of alpha receptors. There's alpha 1 and alpha 2. Alpha 1, when they are agonized, when they are turned on, would primarily can have like vasoconstrictive effects of like non-muscular areas, so like the intestines usually. Also dilating pupils when they are agonized. A little less important, not something we target therapeutically very often, but they might have their niche use cases. Alpha 2 receptors were a bit more complicated, as you might remember. They at first increase norepinephrine for a very short period of time at very low doses. But then negative feedback decreases norepinephrine. So it would actually, since norepinephrine is a target of alpha receptors, an alpha 2 agonist would, for example, in a way, sort of be an inverse agonist of an alpha 1 receptor at high enough concentrations, because we'd be lowering that norepinephrine. Inverse agonist isn't technically the correct term in the fact that an inverse agonist needs to be an agent that binds directly to a receptor. But I think a better term would be alpha 2 agonist would oppose alpha 1 agonist. That would probably be a more technical description, just in the fact that there's less of that norepinephrine. So what's the turned off form of vasoconstriction? Well, no vasoconstriction, right? We're not going to dilate these vessels. We're just not going to constrict them. Same with pupils. Our pupils aren't going to be dilated. They're just going to be quote unquote normal size, because obviously they're always changing to like adjust for light. But that's, the pupils wouldn't be encouraged to be large. Alpha 2 antagonists would just prevent norepinephrine regulation by alpha 2 receptors, right? So it's like, since they increase and decrease, it's hard to make like a statement on what it would do exactly. You can see here that we only have one drug, and spoiler alert, it's not really used pretty much ever. But it would be a way to regulate norepinephrine differently. So this would be, we would probably use an alpha 2 antagonist if we wanted more norepinephrine in the body. But we never use Yohimbe, and I'll be honest. It's used for erectile dysfunction or chest pain sometimes, but yeah. So let's go through some of these drugs, right? We have our non-selective alpha antagonists. These are used for conditions like pheochromocytoma. Non-selective and alpha 2 selective are pretty uncommon, whereas alpha 1 selective are relatively common. You'll definitely see these a lot more in practice. But to start off with non-selective alpha antagonists, pheochromocytoma, this is a type of cancer. And this is a tumor of the adrenal medulla. This is where norepinephrine and epinephrine are formed. So if we antagonize the area that would secrete, or we antagonize these receptors, right, that would respond to norepinephrine and epi, because we have too much norepinephrine and epinephrine, we have things like high blood pressure, high heart rate, things like that, right? Things that we don't always want, because we're not always in a fight or flight situation. By having something like phenoxybenzamine bind to these receptors where norepinephrine and epinephrine bind, we see less of those negative effects. And if you remember, norepinephrine and especially epinephrine will bind both beta 1 or alpha and beta receptors. It's useful to have a drug that can kind of target the alpha receptors. We also have beta antagonists. You could use this in tandem for a pheochromocytoma, especially if it was a lot of epinephrine release and less norepinephrine release. But especially for the norepinephrine, which is, again, a mix of alpha and beta, but primarily alpha activity, these drugs are pretty useful for fighting against norepinephrine. Like I mentioned before, some of the sweatings, hypertension, headaches, heart palpitations, especially these two, just based on the symptoms we've learned about. Alpha-1 selectives will essentially prevent constriction of blood vessels. So when would we use these? So as I mentioned before, alpha-1 agonists increase blood pressure. So these are agents which can decrease, I don't want to say decrease blood pressure, right? They do decrease blood pressure, and that's why we use them. But remember, I think a key to consider is it's not that they dilate the vessels. They just will not constrict the vessels. They will prevent the vessels from being constricted. So an alpha-1 antagonist will essentially just be no constriction. And this is good for like our blood vessels, right? Drugs like prazosin is probably the most common, although I will be honest, none of these are very common, at least not for hypertension. I'll get to that in a second. Prazosin is probably the most common one for chronic hypertension. And the fact that you will not be constricting these vessels just from natural hormones in your body, epi and norepi. Yeah, so it'll just make your blood pressure lower, which is good for most patients. What we do use selective alpha agonists for, though, is this is an alpha-1A. Sorry, that should be a capital A. Alpha-1A receptor antagonist. I mentioned before on the previous slide that there's like subvariants of alpha-1 and like beta-1 receptors, and it's usually just the number and then the letter, whichever it is. Alpha-1A is going to be the most common you see for tamsulosin, and this is used for a condition called BPH, or benign prostatic hypertrophy. Essentially, if you are, this can occur in females too, but this is primarily male patients. Your prostate will never stop growing as you age. It just doesn't. That's why where the hypertrophy comes from. The benign comes from the fact that this happens to everybody. It's not like a cancer why it grows. It just does. I think that has to do with like testosterone and some other factors. It's not really important why it happens. But essentially, your prostate will eventually get to a size, in pretty much all males, if they live long enough, to where it will cut off your urinary bladder to the outside world. It'll make it very difficult to urinate. And some of these blood vessels that would normally constrict sphincters, or I'm sorry, not blood vessels. Alpha-1 controls sphincters in your urinary tract. And by antagonizing these, you can make sure they are open. Now, if these sphincters are open, right, it would essentially make it easier to urinate, because sphincters are essentially the only thing protecting you from like urinating or defecating or like in other parts of the digestive tract, like food moving through. So in this case, it's like even though your prostate is enlarged, we can't control the prostate getting larger, but we can control other aspects of your urination to make urination easier for you. And that's what alpha-1A antagonists do, like tamsulosin. I believe also silozosin, which isn't on here, and I know I'm going to spell it wrong. Silozosin? Question mark? This is also an alpha-1A. It's probably not spelled like that, but you might have also seen that one in practice as well. These are a lot more common, the alpha-1A antagonist, as opposed to just the alpha-1 antagonist. Yeah, so that's pretty much that. Really quickly, I'll just go through indications. I kind of already have. Just alpha-1, right? Lower BP, kind of. Not very good. But like prazosin, doxazosin, terazosin. Selective alpha-1A, tamsulosin, right? We talked about it. Benign prostatic hyperplasia. I think that's interchangeable with hypertrophy. Maybe not. Maybe I just made up a medical term, but that's okay. Again, relaxes those sphincters, makes urination easier. Yohimbe, it's like ED, yeah, ED, and I think heart failure also. Um, Not very common. Labetalol is interesting. So there are like mixed beta and alpha antagonists. They'll do both. They're like the opposite of epinephrine, which instead of agonizing both, they'll antagonize both. And labetalol and carvedilol are one of those. So I'll write this down. These will definitely come back in therapeutics. They're just pretty interesting, and they lower blood pressure in two ways, right? Because if you're blocking beta 1 receptors, which these will do, you're lowering that heart rate and you're blocking alpha 1 receptors from constricting. That'll also lower blood pressure. So it's like a two-factor kind of thing. And labetalol and carvedilol do that. I didn't really talk about that on the slide because, again, they're like mixed. They have alpha and beta activity, but good to know, right? And then finally, like phenoxybenzamine for pheochromocytoma, just that very niche tumor. So that's a drug you probably won't see super often. There's also some medchem on this slide. I don't know, just to put a picture on there, honestly. But because you'll probably be expected to know kind of what a catecholamine looks like. You won't be expected to know what these look like. I'd be very surprised if they change that for this year. But yeah. Okay, let's finish this video up by talking about beta receptor antagonists. If you remember, there's technically 3 types of beta receptors, but I'm only going to be talking about 2 of them really. Beta 1, which is only in the heart. So beta 1 receptors, when they're agonized, increase heart rate. And when they're antagonized, heart rate will decrease. So you can imagine in most cases it's a little more useful therapeutically, like, right? Like we don't want heart rate to be too fast for like a heart attack or blood pressure to be too high for a heart attack. Beta 2 receptors are a little more rare in the sense that we kind of like all the effect beta 2 receptors have, right? They will, on their own, when they're agonized, they will dilate vessels on skeletal muscle. So they'll automatically lower blood pressure when they're agonized. They also dilate our bronchi, the air tubes in our lungs. So like if we cut these off, we're essentially making it so people's blood pressure gets raised and they can't breathe as well. So because of that, we really don't have beta 2 selective antagonist. There might be some examples you can prove me wrong with, but very generally we will either use like mixed antagonist or beta 1 antagonist because those actually have clinical uses. So let's just get about those. The first generation were like non-selective betas. Really the one you should recognize off this list is propranolol. Again, since this is non-selective, it affects both beta 1 and beta 2. And this has a few uses. The main uses is hypertension, high blood pressure, because even though we are preventing this dilation, we are also preventing this beta 1 heart rate, which ends up having a greater effect on the blood pressure. However, it's a first-gen agent, right? We have better agents now. Something else this is also used for is actually stage fright, which I think is kind of interesting. Apparently, if you have really bad stage fright, some doctors will just write you for a few propranolols you can just take. And I think the rationale behind this is if you're anxious, if your heart's beating really fast, the propranolol will slow it down, almost like artificially make you less anxious. It's so strange. I've never understood that, but I think that is a literal indication for this drug. So kind of a fun fact, I guess. You'll see your beta 1 selectives a lot. You will see metoprolol a lot. You've probably seen atenolol. Might have seen bisoprolol. I think the only time you'd really use bisoprolol is I think it's indicated it's either in heart failure or in pregnancy. I think this one's heart failure because I think it's metoprolol, carvedilol, bisoprolol. Yeah. Okay. Sorry, I'm just like thinking to myself. Labetalol is used in pregnancy, which is it's actually on this list right here. Look at that. So yeah. So this one's pregnancy. There's like an indication for that, so you might get that in like therapeutics. And this one is heart failure, bisoprolol. And the only reason that is on there for heart failure is it just has some clinical data with that. Otherwise, it's not really a beta 1 selective blocker we use a whole lot. Metoprolol is going to be your big one, especially metoprolol succinate. There's 2 salts of it, but now I'm getting like way ahead of myself. That's just therapeutics. Basically, these will only work on the beta 1 receptors, right? So they will only affect heart rate. Next up, 3rd gen. Now these are labetalol, we already circled one, and we did talk about this on the previous slide too, actually, and carvedilol. These are mixed beta and alpha antagonists. So they're non-selective beta. So similar to propranolol, they will hit both these beta receptors. However, they will also hit alpha 1 and alpha 2. Alpha 2, you kind of just, it's not really there. It affects it, but like, I think I've mentioned at this point how complicated alpha 2 is and why it's clinically not really a target of antagonism. But alpha 1, on the other hand, preventing that constriction of blood vessels, we like that for hypertensive drugs. So that's why we use carvedilol and labetalol. And I have never honestly heard of a 3rd gen beta 1 selective. The Vivalol, I guess I've heard of in some cases. I think they're all still brand name only, and since the other drugs just have more data, we don't really use them. Maybe one day when they have some more data and they have a generic, we'd use them more. But for now, just don't worry about them. So, sorry, I'm reading through my note. Oh, okay. Here's something interesting actually about Nevibolol. I take it back. I did have a note on this. So there is one special thing about Nevibolol. You will not be asked this, but I thought this was kind of cool when I found this out. So it's a beta 1 antagonist, right? So it will lower that heart rate. It's same as all these other drugs we talked about. It is actually a beta 2 agonist, meaning it will dilate the vessels. So similar to this, right? Because we've been pointing antagonism arrows to this the whole time. So when we've been talking about antagonism, it essentially does the opposite of these. This will dilate the vessels. Nevibolol will. It's the only one that'll do that. Which, like we mentioned before, right? Beta 2 is good. We don't usually like to turn it off if we don't have to. This is the first drug that's been able to turn off beta 1 and turn on beta 2. So that's kind of neat. But again, very rare in practice. Not really a huge thing. Why are beta antagonists used? These have a lot more indications than alpha antagonists. Hypertension, right? High blood pressure. We've been alluding to that pretty much this entire time. Heart failure. I mentioned that with bisoprolol. You'd essentially use like a beta antagonist to lower heart rate and decrease blood pressure, which is important for heart failure. Arrhythmias as well. If your heart is beating too fast, you can use a beta blocker to slow it down. Also glaucoma. We talked about that more in the eye video, so I won't retract that here. But just for the same reasons, it kind of changes how the aqueous humor outflows to a more favorable way. A really big contraindication of beta blockers, especially your non-beta 1 selective, so your non-selective ones, you want to be careful in patients with COPD and asthma. We mentioned that before, beta agonist, especially beta 2 agonist, will dilate those blood vessels. So if we all of a sudden have a beta antagonist, we're suddenly making it harder for that patient to breathe, which is not good. So avoid beta antagonists, really both beta 1 and beta 2 in COPD and asthma, but especially beta 2. Like, don't use propranolol, don't use carvedilol or labetalol. You can use nevibolol because that's actually a beta agonist. It maybe dose it differently because you wouldn't want too much agonism, but yeah, just being able to recognize that. A black box warning of beta antagonists is abrupt discontinuation. Since these have effects on heart rate, stopping them really quickly, and I assume this applies to dobutamine as well, which if you recall was that beta 1 agonist. If you stop these, there's almost like a rubber banding effect with your heart rate. It's like a compensatory thing, but your heart essentially gets shocked. So we'll just like write down heart shock so you have something to watch while I talk. And discontinuing these really quick without titrating your dose down, it will cause your heart rate to either be really slow or really fast for a period of time, depending on if you're on an agonist or antagonist, which can obviously lead to whole bunches of things like if your heart rate's too low, then it's a clot. If your heart rate's too high, it's like a heart attack. Either way, it's really bad. So if you have a patient trying to get off a beta blocker, don't tell them just to stop. Tell them to like slowly go down on their dose so they don't kill themselves. What else do I have here? Going back to like our epinephrine examples, I did mention earlier that we might have something where epinephrine can kind of work as both. So right here we have two things, right? We have blood pressure from epinephrine and then introduction of like a new drug. And we need to figure out what drug is causing this. So you can see that epinephrine, right, when it's administered in the presence of not this drug, this side is the new drug, blood pressure will go up a lot. But if we have this drug, which we assume is an antagonist, blood pressure suddenly goes down. Really lower than even, it's like at baseline still when we draw that line over. So what would cause this to happen? And this is kind of more just an example problem, but this will probably be on your test. There's always like a version of this question. Essentially, if you remember, epinephrine is a beta and an alpha agonist. And what this question is essentially asking is what aspects of beta and alpha agonism will raise blood pressure? There's two. So alpha 1 will raise blood pressure through vasoconstriction. And beta 1 will raise it through heart rate. It'll raise blood pressure through heart rate. So if we were to suddenly block one of these to where it would lower, we essentially have two options. We could have an alpha 1 blocker, right? So alpha 1, because that would prevent that vasoconstriction. The blood pressure would not rise. There'd still be the heart rate aspect, but if you remember, beta 2 is also something that epinephrine hits, which is a vasodilator. Or it could be heart rate with beta 1, right? And the fact that less heart rate is less blood pressure due to that equation we showed on the previous slide. Now, what can we tell from here? So our blood pressure is about the same. Something that can actually happen is, and this will be a question to some regard, is the reason we can tell this is an alpha 1 or a beta 1 here is because the blood pressure is at baseline. And because of that, we can pretty much assume that this is like most likely an alpha blocker in the sense that we're not raising the, no, wait, I'm sorry. This is most likely a beta 1 blocker because for one, we have this cardiac force down here, right? That pretty much gives it away because that's going to work on beta 1, but we also have this. A different interpretation of this problem, if this wasn't a beta 1, would actually be if when we did this whole experiment, not only did our blood pressure go to baseline, but it was more like this line all the way down here. It is actually down from what it was. So let's just pretend this is our systole, because I believe these lines are systole and diastole. So let's just say this red line, these red lines are our systole. So all of a sudden, we take this drug, epinephrine actually makes our blood pressure lower, and we alluded to this. This would be us blocking alpha 1 vasoconstriction. This would be an alpha 1 antagonist. And the reason for this is our blood vessels still have this beta 2 agonism, right? Beta 2 blood vessels dilate when they're turned on, and epinephrine will turn those on, but it also turns on alpha 1, so it kind of balances. But if we turn off that alpha 1, epinephrine, like I said before, can actually lower your blood pressure, which is pretty interesting. And yeah, there is the heart rate effect, but generally, in like 90% of cases, this isn't every time, it's resistance has more of an effect on blood pressure than heart rate does. Again, not totally correct, but resistance is greater than heart rate for blood pressure. Blood pressure, like 90% of the time. So just something to note with that example. Kind of weird, but just understand that, you know, like you can solve this problem really easily if you just look at the contractile force of the heart, because then you instantly know, oh, it's a beta 1 receptor, it's the heart. But if you wanted to think about it a little more in depth, or if you were only given this top graph, that's how you would go about solving that. And then I'll finish off with like indications. So like we said, non-selective beta, lower heart rate BP, yeah. Heart rate, BP, pretty similar across the board. Hypertension for these, also arrhythmias. Um, Beta 2 receptors, no clinical indication. We talked about that, right? Because beta 2 receptors, when they're agonized, kind of just let us breathe and have low blood pressure. So we really don't want to use those. You can use that in like a research study, though, I guess. It looks like that's butoxamine. So I don't know if you ever become a researcher, maybe look into that one. Non-selective alpha and betas, like carvedilol. Heart failure, also blood pressure. They're used for both. Esmolol is primarily beta 1 over beta 2. Again, similar to like this column up here. These are all pretty straightforward compared to alpha agonist, I think. You can read that chart a little more carefully, but all you're going to be asked really is like blood pressure, heart rate. Like that's kind of what we look at when we look at these. But with that, thank you so much for watching and good luck on your exam.